Never came.
No, he did come. I gave him a seat.
Oh, good. Where is
Should
he?
be all set, I think. He was also, another person was coming with him, I guess.
No, he isn't.
Yes, he is. He just told me.
He's not. No, he isn't.
He just
Actually, he was here, Joan. I don't know where.
Welcome to the Kennedy School of Government. This is the first in what we hope will be a series of many forum events, public debates, brown bag luncheons, and other discussions on issues of healthcare reform sponsored by the Kennedy School's Malcolm Weiner Center for Social Policy. This evening's panel, Pete Stark, Bob Blenden, and Joe Newhouse are going to be talking to us about some of the basic issues that are before us as the country begins debating healthcare reform. When we think about healthcare reform, I think what we first think about is the enormous contradictions in the American healthcare system. We have the best healthcare system in the world, but we don't necessarily have the best health in the world. We have world-renowned hospitals that treat people from all over the world, and yet some of our citizens can't get access to healthcare. We have remarkable technology, a very productive scientific community that generates research in the area of medical technology, medicine, and issues of health and healthcare reform methods, but the costs are many times too great for our budgets to bear. As the topic of healthcare reform is discussed this year, these issues of quality, cost, and access will continue to be raised. We know over the past several years these issues have been raised in many quarters. State governments, local governments, private companies, hospitals, and individual physicians have been tinkering with healthcare reform at the margins. Now we have before us the opportunity to make some major changes in the way healthcare is delivered and financed in this country. This is going to be a long debate. It's going to be a debate where many voices are heard, many perspectives are heard, and what seems to many of us to be most important is that we create forums for discussions of the issues, that we not reduce them to sound bites. And our hope is that this series of events will help in that process. Our first speaker tonight is Congressman Pete Stark. Congressman Stark is now serving his 11th term in Congress. He represents the 13th District of California. That's just on the east side of San Francisco Bay, I believe. He's a member of the Ways and Means Committee, whose scope includes Medicare, Social Security, taxes, trade, and public assistance. It's one of those small committees in Congress. In January 1985, Congressman Stark assumed chairman of the Health Subcommittee. In the past, he's presided over a number of major changes in Medicare. He is now about to reach one of the biggest health care agendas that the committee has probably seen. Lest you think he might not have the resources to do this, Congressman Stark was also active in the tax reform debate when he was on the subcommittee on select revenue measures and was one of 22 members of the House and Senate who were part of the tax conference which culminated in the 1986 tax reform. So he's had a lot of experience in getting major issues like this through Congress. Congressman Stark.
Thank you, Julie. You were kind not to mention perhaps my greatest legislative accomplishment, which shows my legerdemain and my ability, which was the catastrophic health care bill, which not only being the greatest piece of health legislation ever that passed in this country, but also the shortest lived. And so now it's the administration's turn, And I might make a liar out of you and talk in sound bites, but I'll try and, as I lead off, I'm not sure whether I'm going to set the tone for this, because in this academic atmosphere, I'm not sure my tone is what you want to follow. But I'd like to talk for a minute or two about the administration's health plan from my standpoint, and I'm sure my prejudices will seep out as I talk about it for a couple of minutes. I'd like to identify my role because the committee that I chair and have chaired for, I guess, 8 years now, runs the Medicare system. It basically is the board of directors. There are 11 of us, currently 7 Democrats and 4 Republicans. And because we have to originate the legislation, we take some precedence over the Senate in this regard, and we specialize. The health subcommittee of the Committee on Ways and Means does in fact have not much else to do except running the Medicare system. That means that we've spent an awful lot of time running a payment system, which is what Medicare is. And we're justifiably, I believe, proud of what we've done for the taxpayers, for the beneficiaries, for the providers. And so a lot, and that's about all I know about the intricacies of providing health care to Americans. I understand the financial aspect of the Medicare system and the cost problems that are involved in a federal program. The president has been advised by a group, maybe some of you have been there, who in the first 6 months of this administration have knowledge far transcends that of our subcommittee and indeed of our staff. So I'm a little bit in awe both of their wardrobe master and their staff. They have a plan, and I want to quickly give it some high marks in some areas which I applaud. First of all, the goals are well articulated, and I think that he has found a common set of goals that every American can agree to. The idea of comprehensive coverage for everyone, and I presume he means coverage and access. He doesn't quite live up to the standards that I would impose in terms of undocumented workers or aliens, but that's a political issue that he may be forced into whether he likes it or not. He has taken to what is, in my mind, the most courageous step, and that is to say that every American employer will pay something. And believe me, I think that's right. Most of the bills that I've ever worked on or co-sponsored or dreamed of would require that, principally not because philosophically you could make a case that an employer ought to pay. We probably all ought to pay. But a large number of employers, the majority of employees work for employers who do pay and have been paying since health insurance became the province of employers back in 1940. And it's very difficult to construct a case, it seems to me, to let anybody out of the box, to not participate in paying that share or assuming that financial burden, whether it's Zoe Baird or the Boston Globe for the newspaper boys or all of the great things, the Girl Scouts peddling cookies door to door, perhaps, if their wages exceed a certain amount. The point is that if we really mean that everybody's going to pay, then we'd better mean it. To me, that's a courageous decision. It could be a linchpin. It's a major decision it's a major point of division between the Republicans and ourselves. But the president is right on, and he's to be commended for that. He's caught on quickly to the simplification issue, which is probably the easiest problem that we have to solve and probably is the least contentious, but he's been very, very forthright on that. And that's where, as far as we go down the road together. Now I have some problems with other parts of the bill, and I'm going to assume that most of you know what's in the bill. He has put a tremendous reliance on the states. And I have no quarrel with states being given broad opportunity to opt out, to go ahead and create, whether it's Vermont and they want to create a single payer plan, whether it is Maryland, who now has a waiver from Medicare and has a special plan for paying their hospitals, which I think is quite good. And I'm not sure that any other states have a plan at this point that requires or mandates universal coverage. Hawaii comes close. But when you look at Hawaii, you say, wait a minute, 94% coverage, 6% uninsured? That's 1,200,000 people in California. I'm not sure that for me, 94% gets them any great accolades, because what they basically left out are the underemployed, unemployed, part-time employers, impoverished, or those with crippling conditions that keep them from working in the first place. That's what this whole system is all about right now, is finding coverage for 37 million Americans. But imagine this from a political sense. Governor Wilson in California, who measures right up there with Dracula in his ability to provide social services to the poor and the disadvantaged, has already said that he will not support a mandate and that this plan is unnecessary and he won't support it. Well, there's 20 million people in California that aren't going to be in the plan unless you think Willie Brown is going to be the next governor. And so California probably won't support this plan. Oregon, earlier this week, I think it was Monday or Tuesday, the Oregon State Legislature voted down the idea of universal mandates on all employers. So as bad as the Oregon plan was by rationing only poor people, even if they could have straightened it out, they've just voted against the mandate. There's 2 states down. Now imagine Dick Armey. That may spoil your evening, but imagine Dick Armey going back to Texas and going to a town meeting like this and saying, I'm going to guarantee you universal coverage, and I'm going to guarantee you protection from runaway inflation, and you should be comfortable with this federal plan. And somebody's going to raise their hand and say, well, Congressman Armey, how are you going to do that? Well, I don't know, because I'm leaving the details up to Governor Richards. That is a conversation you will never hear, any more than you will hear Dan Rostenkowski go back to Chicago. And Mrs. Kowalski will raise her hand and say, Congressman Rostenkowski, how is this plan going to work? Dan's going to say, I don't know, Governor Edgar's going to write the details. This is not going to happen. And there won't be 50 states writing 50 identical bills to run 50 identical alliances. It is just it's sheer political conjecture, and I don't believe can happen. What I think should happen is that the federal government, if in fact we are going to pay for any of this, and I rather suspect that's what they're looking to us to do, we have a responsibility, in my opinion, to be able to go home and say that if all else fails, we are going to provide access and coverage for everyone. We're going to provide a decent set of minimum benefits, and we're going to ensure some quality. Now, if a state chooses to opt out, fine, if they meet those standards. And that means we're going to have a preeminent federal plan from which the states can opt out, at least in my opinion. Cost containment is an issue that is one of the prime cornerstones of keeping our health delivery system intact. And we have done it in government plans, and in the process of doing it, we've shifted all the cost onto private plans. The president has come up with a plan for the private side of the medical delivery system, and figured that now the federal government picks up about 40% of the tab for medical providers, and the private sector picks up about 60%, and you can vary that depending on what you want to do with Champus and the veterans and so forth, but it's around there. If we say that we're going to control our 40% side and continue to control it as we have by setting prices and fees, then we have to have a system that's going to prevent cost shifting. The idea of premium caps and or competition, I don't think works. I like to always ask people, if those in an audience who may favor competition in medical services, to just play along with me. And I went to MIT, I shouldn't really say this, probably ruin his practice, but with Jerry Austin, who's now at Mass General, and he's arranged tomorrow morning between 8 and 9 for any of you here who would like either a proctoscopic examination or a pap smear to get one for 50% off. Now, I'd like to know how many of you are going to run down there tomorrow morning, because I've got this bargain for you at arguably at a good institution to get one. And the answer is you're not. We don't do that. That isn't the way we buy medical services, and I'm sure that that's not the way we are going to, the Jackson Hole group notwithstanding. And so I think that this idea of two kinds of cost containment on two sides of the system are a formula for disaster. While I don't like the premium cap idea, it still might be better to have a uniform system on both sides, because you cut down the amount of gaming that I think will invariably happen. There is, to me, and this is pure conjecture, suspicion, and paranoia. Jim McDermott, who's on my committee and is a psychiatrist, says that I should not worry about paranoia. People really are out to get me. And but I just cannot see how you will prevent the exacerbation of a two-tier system under this plan, where a fee-for-service, although it may be somewhat more expensive, is still available, because I just don't see folks all running higgledy-piggledy into the finest HMOs, and you have some here in the Boston area. We have some in the East Bay, but in South Carolina, I don't think any exist. And when you begin to tell people that they can't go to Mayo's, or they can't go to Mass General, or they can't go to Johns Hopkins, I think you begin to run into some problems. And I think people will pay for that. Those of us who are paid high enough salaries to be able to afford it are going to do it. And it's probably not a bad way to spend your money. But I think that will just exacerbate the problems, and that there are communities and areas of the country where I don't think HMOs are going to go. I happen in my spare time to be the de facto mayor sometimes of the District of Columbia, chairing the district committee, and we have 250,000 people who are either Medicaid eligible or uninsured, and they haven't got any, nobody wants to take them. And Prudential has already said they won't, and I don't know if there's any room for them in any of the other HMOs, and I don't know if the problem is solved for those people in this bill. We'll spend in Congress the next couple of months shedding a lot of light on this plan. There are no details. We could get into them tonight, and I can tell you what I've heard and what I think, but there's a 239-page booklet. I'm in competition with that copy shop down at K Street. I sell them for $20, and that's after I pay the government back for the paper. And there aren't any details. And there are a whole lot of, well, we'll fix that laters, and there will be details. It's my understanding that there are somewhat up to about 1,500 pages of drafting now, and after that gets to wherever it's going to be, we start to crunch numbers. And just a word on that. You will hear a lot about numbers and projections of costs and revenue and all of that. And far be it from me to criticize an economist. The point is that in Congress and in the White House, we have to march to two drums. For spending or savings, it is the Congressional Budget Office. Whether we think their assumptions are correct or not, their estimates are used by us by law to set the budget targets which we must meet by law. And the Joint Committee on Internal Revenue Taxation, which advises the House Ways and Means Committee, and the Senate Finance Committee, estimates what revenue will be. We're going to charge $1 a pack for cigarettes. They'll tell us the estimate, and they may estimate that some people quit smoking, so the revenue will go down, and so forth and so on. But whatever that is, we can disagree, we can grump, but we live by it. Now, the president doesn't yet have those estimates. And I really don't care, and I keep telling him he shouldn't care. They'll be what they'll be. And if the costs are too high, we have to lower the benefits. And if there ain't enough revenue, we got to find some taxes to do it. And why we're in that debate at this point in time, when we don't even know exactly what the bill is going to be, eludes me. But you will hear a great deal from the White House about how many economists agree on their revenue estimates. And I'm sure that all of the economists that agree are listed. Now, those that don't agree, I haven't heard about, but there may be some. We're going to start hearings, and we will hear from all these people. We have the details. By Thanksgiving, my guess is that the House and the Senate will have had more hearings than any of you care to think about. C-SPAN will be inundated with what will become increasingly complex, dry, dull recitations of numbers and statistics. And at that point, we're going to have to sit down, and then the fun begins. And that is, how do we find out all of these pieces and ideas, 218 votes in the House of Representatives, to get a bill that the president will sign? I can't even begin to think what will happen in the Senate, where you'll have at least 50 people who run around with a veto in their pocket. And I would love to talk with any of you or come to a seminar where you discuss the merits of unicameral legislative bodies. I would be glad to pay my own way up to come and lecture on those. But you're going to have, in my estimation, at least 2 bills in the House which will have substantial support. I don't include the Cooper managed competition bill, which will come up, but I mean, out of the legislative process, Energy and Commerce will probably write a bill, as will the Ways and Means Committee. They may overlap a great deal, but that has happened often, and there's no problem. In the Senate, you'll have at least 1 bill, possibly 2, a Republican and a Democrat bill. And at some point next year, we'll have to get together and take the pieces of those various bills and see whether we can put together a health program that works. And when we're done with that, we'll all have to come and see Professor Blenden and have him tell us whether we'll get reelected or not if we vote for the darn thing. And so I'm waiting to hear what kind of trouble I'm in already in my district at home. So you'll get much more information from what we ought to do than the normative sort of things from him. Thanks.
Thank you, Congressman Stark. Our next speaker is Robert Blenden, who is Professor of Health Policy and Management at the Harvard School of Public Health and Chair of the Department of Health Policy and Management. He is not an economist. He directs the Harvard program on public opinion and healthcare. He also directs the Harvard program on the future of healthcare, and in addition is the Deputy Director of the Harvard University Division of Health Policy, Research, and Education. That's a lot of hats, and I'm impressed that you still have time to do some thinking and do some writing beyond running all those programs. Prior to coming to Harvard, Bob Blenden was Senior Vice President at the Robert Wood Johnson Foundation. And if you don't recognize Bob by seeing him, you may recognize his voice. You've probably heard it a lot on the radio, particularly National Public Radio, as he's talked about the American opinion on issues in healthcare reform. Bob is going to have a few slides, and the slides can only be shown on the large screen. So those of you who, I think, is that right? And those of you who can't see them, should feel free to move around to look, but there will only be a few slides, and it will only be a short part of his presentation, so you won't miss all of it. Thank you. Bob.
Hi, Bob Blenden. Pete chose not to tell you that he took a stand on this issue long before the president, as a candidate, had ever once used this in a speech. Pete was the major member of the House Ways and Means Committee, which is not a place to be for a national health plan until this year. And he was out there very far. and was actually willing to say to a group that was very nervous that there was something to be learned from Medicare at a time that people like myself who were doing polling would say, Pete, take something more moderate in the center. So he likes to call and get a little bit of advice here, but I've been extremely thrilled that he doesn't spend too much time listening to people like me. What I do is track the American mood on this issue, and what I want to do tonight is to help you understand the president's strategy and the problems he's going to run into. What the president's trying to do is use public opinion as a tool. And there are, in Pete's life, 800 organizations that lobby in Washington on health care. Without doing a survey on the 800, their position can be summarized as follows. A small change would be better for our lives than a big change. And now they'll pay a lot of graduates of this school a lot of money to rewrite that different ways. But basically, that will be what you will say. And so what the president is trying to do is make it unacceptable for those in the Congress who actually know nothing about health but have to raise their hand, not to raise their hand for a bill that's an incremental bill. So that's a strategy. So I want to first summarize the speech, which was an enormous success. It not only raised approval of his proposed plan, and recall everybody on the MTA had the plan a month before it was announced, so we all had a chance to study it and Americans had their views. But secondly, it really actually raised his whole ratings as president. But what he did to get the ratings up is as follows. This is what he really said to Americans. Ladies and gentlemen, tonight I am going to offer you the most comprehensive benefits ever offered by any president since Harry Truman. And there will be no taxes. And there will be no taxes. Now, there is a cigarette tax, but for those of us in polling, 3 out of 4 adults do not smoke. So the sacrifice of the 1 in 4 to buy health insurance for those at the table is something that actually we as a nation can survive. So this was exactly the message, and it was repeated 8 times to the audience. And it was so shocking that across the nation, people who went out for a Coke came back in and said, Harry, when did he mention the tax? Because, see, the night before, polls showed that 80% of Americans expected him to announce a major new tax as part of this plan. But there was no major new tax. In addition, he decided to low-key the major changes in healthcare delivery that are about to occur. And basically, it goes like this. Americans are willing to gamble with managed care plans, but only if the benefits are great and the taxes are low. Most Americans believe that they will not be better off in managed care. They think it'll be okay, but not better off. You'll only get them to go along if you buy them with benefits. So the president didn't discuss that, and as I'll show in a moment, the response afterwards is exactly that. And what he said to is, I will do this, and I'm going to share a set of values with you. And I do not believe presidents write speeches off public opinion polls. It just happens his core values are enormously popular. And so you know what happens? Science has these accidental findings. So let me see if I can summarize the core values and the popularity. And one, this has been a problem for Pete. Americans believe at the moment that the role of government is the police, but private sector should manage the health care plans. And basically, the public hates the insurance industry, but doesn't yet trust the government. So the compromise is that one has a shotgun on the other, but the private sector manages it. 2, America is divided in this argument between competitive plans and regulation. And the division is more than the fact that most Harvard professors like regulation and most Stanford professors like competition. It turns out that people who feel comfortable with competitive plans tend to be better educated, business school graduates, work for businesses, West Coasters. The people who are very nervous about competition are people who are union members, seniors, people on the East Coast, and people who actually have trouble with a lot of information. This is going to this is going to bother you a lot, but all the advocates for managed competition discuss the report card. The average reader of Consumers Union has close to a PhD. The idea that average people, language problems, reading problems, will go through hundreds of pages of information is very threatening to people who can't attend this school. And so there is a very big class education difference about what you want. So what the president did was hit them both. And if you listen carefully, you had private sector managed plans with government price regulation of insurance. And the liberals went home and said, well, it's not what I like, but I'll get them. And the conservatives said, oh, this regulation stuff we'll get rid of and we'll have private plans. And across the nation, he was able to touch that. In addition, he dealt with the American value system, which is not the Canadian value system. That is, Americans want a choice of plans, and what they mean is, and I'll say this quite crassly, if I have the money, I want the ability to buy up. And I've done the surveys on this. We are not Great Britain here. We are not in the same boat. And you will lose at least half of America if you say, just like Pete said, if I got the money, I want to go to the Mayo Clinic. And so he said very nicely that you will have that choice. In addition, he said to every American what Jimmy Carter didn't learn: you don't have to sacrifice. No sacrifice. No cold sweater, remember the energy, get ready, little fireplaces. We will not sacrifice quality of care because we'll get the money out of administrative costs, waste, fraud, abuse. That'll do it. And a single form seen at Children's Hospital will save billions of dollars. God, I feel good about that. And point 5, that the benefits that we have will be paid for by employers and providers, but not me. And so, in my business, we're able to do outcomes research not in years, but in hours. So what did the president achieve? 1 week before the announcement of the plan, only 43% of Americans said that they intended to support the Clinton plan. 3 days after the speech, 56. Opponents were 41% the week before. Opponents went to 24%. The rest just don't know. Those who said that the Clinton plan was better than the existing system went from 52 to 64%. The president's rating jumped by 10. Now watch very selectively what the audience took away. Now, the president has mentioned this security card a few times before, but it has not been a major piece to the speech. Now, asked 3 days after the speech, what did you take away? 64% said, I get a security card. 68% said, I get mental health benefits. 74% said, I get preventive checkups. And only 36% said managed competition was involved. See? What he did was buy the American public benefits, no taxes, and a set of values about government's role. Now, I would like to sit down and say, with that strategy, he's got it won. Just the in-town problems, but outside. But see, the opposition has an opportunity to turn this around. And let me see if I can deal with this. There are 4 issues. And what turns out in polling and political consulting is all you do is ask people a very simple question. If you heard something about the president's plan, is there any likelihood it would make you not support the plan? And there are 4 things that if you tell people enough, they'll do. One is about 40% of Americans want to hold on to their doctor. The rest are willing to take their chances with managed competition, but 40%. Now, the president said you'll have it. But then again, only 35% of people who heard the speech were sure that they'd absolutely keep their doctor. The rest are not sure. So the opponents will work very hard to make you understand that you won't keep your doctor. Point number 2 is this nation, unlike the ethics courses we teach, is unready to ration. We have no willingness at this stage of the debate to confront limiting things. So it goes like this. 71% of Americans say that they would oppose Clinton's health plan if they heard it involved rationing for seniors. Well, he's taking $40, $50 billion right out of the Medicare program. Excuse me, absolutely, 120. Let's not lowball this. So there is a possibility that you could raise this issue. that when the seniors get to hospitals, that the services may not be same, or doctors. They already have a base. 37% of Americans say that they're sure their quality of care will go down with the Clinton plan. All they need to do is find 30% more to hold that view, and you lose it. Then we deal with the big tax increase. Across America, people just said, Dan Rather, where is the tax? So he told us there is no tax yet, and this is amazing to me, 80% of people who heard the speech said there was something wrong with the financing of his plan. Now, I thought you had to take Joe Newhouse's course to know that. And so without a degree, they knew there was something wrong. 74% said that they expect a big federal tax increase somewhere down the line here. What's important about that is we've had a change, which the president just gambled on. Since June, we have shifted from the majority of Americans who said they would pay a tax for a national health plan to last night where 59% said they would pay nothing. And the president said to them, that's okay to believe. You can have all this for nothing. And so what the opponents are going to say is, lurking in this plan is the world's biggest middle-class tax increase that you ever saw. And we just agreed with the president that night. It's free. So why should we want to do it? The next point that people are going to go after are loss of jobs and the recession. And we will see across this country the 1 million jobs lost because we require employers to offer insurance. And it turns out, as I'll show you just very quickly in a slide, that Americans value national health reform more than anything but loss of jobs. And this was the issue in the California Proposition 102 where it actually failed. So the president's dilemma, and we're talking about out of town here, the dilemma he has is that the opponents will have really 3 advantages. One, they will have money, because soon as you cap expenditures, we're dealing with 1/10 of the American economy that makes a lot of money and can buy a lot of New York Times ads. For you don't know, it's $65,000 an ad, and that is quite a club to belong to. But the people who are going to lose out in this reform can afford that ad. 2, the plan is not the first choice of the majority of Americans. And this is Mrs. Clinton and the president's absolute dilemma. In a survey that was just done last week, which corresponds to all others, Americans were given the 3 choices once again: the Republican tax credit plan, the Clinton plan, and a single-payer plan. And once again, they split 1/3, 1/3, 1/3. Now, what that means is 2/3 of Americans are against every plan that you will ever present to them. So what that means is what the opponents will do is say that Clinton's got the values right. They got the plan right. But there was a better alternative. And if we can kill the sucker, we're going to be able to have a better plan. And you know what? 2/3 of people will say, including Bob, that they're probably right. I'm sure there is a better plan. But the dilemma will be is any way you rearrange the plan, 2/3 of people. So if she had given in and picked a single payer, and we were honoring her at Harvard at this moment, 2/3 of Americans would have said she got it wrong, too much government intervention. So you'll be able to say you don't have to have these other problems because she should have picked the other plan. And so this is what the campaign is going to be about. And this is what I want to alert you to, because it's going to be very hard for us in this room to pay attention to what I consider are the key political issues. As the campaign goes on, we will join Pete in worrying about how this plan will work. We will be up to our eyeballs in C-SPAN hearings and adjustments and everything else. The people with the money are not going to waste any time on how this plan works. They're just going to be buying ads over and over again. Rationing, lower quality of care, loss of jobs. Rationing, lower quality of care, loss of jobs. And the middle-class people, you are going to pay $1,000 per person. They're hiding this from you. It's going to come. And as we argue about should the regional authority be 1/3 of the state and 1/2 the state, the ads, the radio spots are going to be over. And unless people like in this room are willing to take on and go on everything from talk shows to citizen groups to talk about the fears of change that are out there, this is what beat every national health plan, not the details, not the structure. We scared Americans that basically the disease was not as bad as the cure. And that's what this is going to be about. So I'm going to show you some very quick slides, only because I was told Harvard professors had to have slides. Aha, what do we have to do that technology? This? No?
No, I don't think so. You may not need it.
Well?
You have to point.
Ah. It is clear? Ah. Well, this is the president's key next speech. Actually, that's reverse it quickly. What this is a preference for who do you actually want to run the system, and the private side dominates government. But that doesn't mean that people do not want the government to regulate the hell out of the middle red bar. The second thing is, I don't know if anybody can see it. The second one shows the division.
Bob, I don't think they can hear you.
Oh, okay.
You can turn these around,
Between the managed competition and regulation, and this is fun. We actually did this survey with Dave Gergen before he went into government, and 1 in 4 Americans we surveyed after we described managed competition and then government regulation said, gee, sir, is there another choice? But basically Americans are quite divided, and it's very class-oriented about, okay, that would be easier even for the author of this. What that shows here is the green bars, which say the one thing Americans want Pete to do is price control, as long as he doesn't manage anything else. And so it's very odd. So what the president did was compromise. What that says up there, I like price controls on drugs, I like price controls on fees in hospitals, all of which are in Medicare, and I like price controls on private insurance charges. So what he did was say price control for drugs on seniors, it's most salient to them, but nobody else. Price controls on insurance premiums, leave the doctors and the hospitals alone. Very split the baby, something Solomon would have taught. Here is the split between the 3 plans, and we can discuss this ad nauseum. This was done 1 week ago, which basically shows that Americans are divided, and no plan ever captures majority support if you mention the others. So those who are single payers want to believe that America is only there if somebody just didn't deprive it of them, and they're there single payer if you don't tell them there's another choice. But if they do know there are other choices, they split. Very real, and so does everyone else. What this says is the ease of people who run the ads to confuse the public because Americans don't know the details, and this is going to pain Harvard faculty. What it says on the left is that 60% of Americans said that they have either heard or know nothing about the Canadian healthcare system. So after all that's published, 96 New England Journal articles, great debates, 60% say don't do it. What's important is one of Pete's colleagues went on television and accused the Clinton plan of being a Canadian plan. And 6 out of 10 Americans wouldn't know the difference. So we're going to see very, very extreme. What that shows on the right-hand side is that no one can identify what managed competition is, single payer is. They just don't know the terms of reference. So this pretty much gives you a picture of what the debate's going to be about. People who are in the politics of this business know that what they want to do is scare people on the 4 dimensions. And unless there is honest, factual discussions, and if you need practice, go on Rush Limbaugh, because Russ will be on this in an hour. And he'll get all 4. You kill grandmom while you're knocking off business and paying a large tax. But this is what the debate's going to be, while all of us are fixated on the structural stuff. That's my message. If you really want to be in this out of town, we have to deal with what the political attacks. Thank you.
Thank you, Bob. Now that we've heard about the Washington view and the out-of-town view, we're going to hear from the economist and get the economics view. Joseph Newhouse is the John D. MacArthur Professor of Health Policy and Management at Harvard. He's the Director of the Division of Health Policy Research and Chair of the Committee on Higher Degrees in Health Policy. at Harvard. I say at Harvard because he's a member of 3 faculties, the Kennedy School of Government, the Harvard School of Public Health, and the Harvard Medical School. Prior to coming to the Kennedy School, Joe spent 20 years at the RAND Corporation, where he's perhaps most well known for having designed and directed the RAND health insurance experiment. That was an 18-year experiment that looked at different ways of financing medical care. And Joe is going to speak this evening about some of the economics issues of healthcare reform, and he also will have some slides, so get your eye shades ready.
Well, ladies and gentlemen, I fear that I'm in trouble because I looked up at Bob's slides and they looked very faint indeed. So I would like to know, as a show of hands, how many people could read the slides? Oh, good. Wonderful. I should be not so pessimistic. So is there a slide on up there or not? No, but all right. I'm going to make, I also want to skip some of my slides, so I may have to come around and look like Bob did. I want to make 3 points about 3 generic issues that are going to apply to both the president's plans that apply to the status quo and that apply to many of the competing plans that I think we will see. And I'll summarize my 3 points for you now. The first is a strategic point. That is, it's important to keep in mind the difference between the level of spending on health care in a year and the rate of change from year to year. And what's been driving us nuts, I think, about health care is its rate of increase, which if I can actually convince myself that I could read my slides and you can read my slides, you might be able to see too. That's one point. And you're going to have to ask yourself, when you hear about savings in the healthcare system, are these savings in a level of spending, that is, are they one-time kind of savings, or are they going to change the rate of growth? Point 1. Point 2, we're going to hear a lot about global budgets as a way to do something about that rate of growth. This is a tactical point. We have some severe implementation problems in the short run with global budgets, not necessarily in the long run. The president proposes to implement them at a state or a sub-state level, depending on exactly where one draws the boundaries of the alliances. We don't know what spending per state is exactly, although I'll show you some data on the Medicare program. And it turns out that that spending bounces around a lot from year to year, which may make life somewhat roller coaster-ish if one is trying to regulate. Finally, I want to make a point about what goes by the rather esoteric term of risk adjustment. What this means is this is a way to try to compensate plans that get disproportionate shares of sick people. All right, if everybody gets paid the same and you have more sick people than in your plan than I have in my plan, you're going to lose money, I'm going to make money. So risk adjustment is a central issue. I'm going to show you some numbers on why I think it's actually quite important. And we unfortunately don't know how to do it too well. So let me see what I can do. Oh, wonderful. I can see. We may see a lot of this in the future. This is, the caption says, I used to just do medicine, but lately I've been moving into economics. All right, this is essentially the message that a number of people, including the president, I think, have or are trying to communicate. There is a lot of waste in the American healthcare system, and we can cut back spending and not give up much. In fact, the intellectual grandfather of managed competition, Alan Enthoven, dubbed American medicine flat of the curve medicine, representing this curve. So you see there's 2 points, A and B. If you move back from B to A, not much happens. Thank you. And lo and behold, as Bob said, we can, if we do that, we can free up some money. We can cover uncovered people. We can provide mental health benefits. We can provide prescription drug benefits to the elderly, et cetera. Now, notice that this curve is drawn at one point in time. Now, there's a lot of evidence for this that I won't go through so we have a little time for questions. But here are the data on the rate of change over time. What I've done here is taken the US for the last 5 decades. And I've gone decade by decade, 1940, 1950. I've taken out inflation, and I've taken out population growth. So what we're left is what economists would call real growth in health spending per person. You can see each year, you go decade by decade, spending went up about 4% a year in real terms, except in the 60s when it went up 6.5%. It's not surprising. That's when we enacted Medicare and Medicaid. 4% a year. All right, the president's going in position is that after 1998, this number should be 0. All right, 4% to 0. And this is an ocean liner that's been chugging away at 4%. Now it's going to go to 0. Now that maybe can be done for a while, but whether we have the president's plan, any other plan, going to confront this. Now why do I say confront it? Because an argument for doing something about this rate of growth is that, as you see on the right there, this number, 4%, exceeds the rate of growth of our GDP. And I don't know any reputable economist that thinks our GDP is going to start growing at 4% a year in real terms. Now, what does that mean? That means we're pulling an ever larger share of our resources into the medical care sector. You can confirm this if you walk by any of the hospitals in town that all have cranes outside them. These resources in the healthcare sector come at what economists call an ever higher opportunity cost. That means what we're taking these resources from gets ever more painful to give up. And at some point, we may want to decide, and maybe we're at that point, it's just too painful to put another dollar, or at least another share of our economy into medical care. I have some slides that try to go behind this 4% and ask what it represents. I've gone through a number of factors such as aging, tried to quantify what it represents. Turns out that none of these factors explains very much of this growth. There's a big residual that one can't account for very easily. And to me, the most plausible explanation of that was a slide to show that we spend more, is what I'll call the march of science. Medicine has ever more to offer, even if it's cheaper on a unit price basis, as for example, laparoscopic cholecystectomy. We buy more of it when it's out there. So we have intended as a country to buy what science has had to offer. And maybe that's what we want, but ultimately the size of our pie is limited, and if we put more there, we take away from something else. I'm going to skip through these slides, except this one is an important slide. It turns out that although we spend much more than any other country in the world, much more, and I skipped over the slide that showed that, our rate of growth is not so different in real terms. Okay? It means we also spent that much more in 1960 as in 1990. What does that all mean? Well, I tried to work through the arithmetic for you on this slide, but since many of you are students at Harvard, I'll assume you'll be able to get it pretty quickly. The bottom line is that we may overinvest in technology in the sense that the last several units of a procedure or a machine that we buy may not be worth very much. But the first few units may be worth a lot. Now what happens if we stop buying those last few units? This is what happens to medical spending as long as we keep buying the first few units of the next technology that comes downstream. We take a one-time drop, but the trend line still goes up. So this is going to be ultimately our problem. It's our problem as a society, independent of the president, single-payer people, people to the right, probably don't want to do anything, status quo. Do we want to keep spending more money on medical care, or don't we? All right, let's, this slide, one last remark. This slide shows how ambitious the president's goal of going to zero is. I said 4% a year for 50 years, going to zero. Here's the G7 experience for the last 3 decades. All right, this is again annual rates of growth. As you'll see, there's no country there that's at zero. Right? There's only one country that's even kind of remote, what I would call remotely close. That's Germany in the 80s at 1.4%. Everybody else, even in the 80s, is around 3 and 4%. Not too different from the US rate of growth. That's to say, no, now we've got some margin because we're spending so much more than everybody else is, and there are real sources of waste in our system. But after we get through that, and nobody knows how long that will be, one can expect that we'll have to grapple with this problem. All right, suppose we go to budgets at the state level or the sub-state level, and we say to Massachusetts, this is what your target is for this year. If you don't achieve it, we'll just reduce some federal grant payments to you to get it back. So you better do it. These are payments under the Medicare Part B program. These numbers actually came from a report done for Congressman Stark. And here I just picked 4 of the large states, California, New York, Illinois, and Pennsylvania. And Part B, by the way, is the part of Medicare that pays doctor. Most of it goes for doctor payments. There's a little bit else. It's not the part that goes for hospitals. And as you can see, to take the most dramatic example, which is Pennsylvania, going from 1987 to 1988, doctor payments in Pennsylvania fell 10%. This is not a few doctors. There's a lot of doctors in Pennsylvania. Next year, they went up 33%. Then they fell back to 7%. Right? Now, anybody looking at these numbers is going to say, now, you said it was 4% a year, or you said it was 0% a year. What is, even Illinois, for example, goes 12%, 1%, 14%. Now, you know, there are potential technical answers to this to ameliorate it, but it's still, I think, a serious issue, and it's an even more serious issue when you get to a sub-state area. Because on a smaller group of people, it's going to be still more volatile. Finally, let me talk about risk adjustment. And let me put up 3 slides to show you what I'm worried about. These data all come from a series of 98 HMOs that entered into the contracts with the government, the Medicare program, in the mid-1980s. And these HMOs agreed to treat Medicare patients for a stipulated amount. The Medicare enrollees were given their choice of whether or not to enroll. And about 100,000 people who chose to enroll were compared against 100,000 people in the same market area that didn't enroll on 3 dimensions. First is on this slide. What did you spend in the year, or sometimes the 2 years before you enrolled? And these are ratios of the HMO enrollee spending to the fee-for-service enrollee spending. For example, in 10% of the plans over there on the far left, the HMO enrollee spending was less than 60% of the fee-for-service spending. On average, those who chose to enroll in an HMO spent 23% less when both groups were in the fee-for-service system. That sounds to me like they were healthier or less inclined to use the doctor. Here's another measure. These are hospitalizations that predict future high expenses. You're hospitalized for X, it's very likely next year you're going to have high expenses. Again, HMO enrollees show many fewer such hospitalizations. On average, they had 25% fewer such hospitalizations. Finally, this is mortality after you enrolled in the HMO against the fee-for-service. This is actually on 83 of the 98 plans where there were mortality data. In 83 out of 83 plans, the HMO enrollees had lower mortality. This is actually after adjusting for age, sex, and other things that go into the Medicare reimbursement formula. Now, this not only means that it's very likely that the HMO enrollees were healthier, but that the costs in the last year of life were disproportionately falling on the fee-for-service. What does this all mean in terms of the president's goals? First of all, it tends to threaten the fee-for-service plan if this isn't done very well. We've seen at Harvard, and we've seen in the federal employees plan that so-called high-option fee-for-service plans tend to get in a premium spiral because they tend to be left with the sickest people. You average the expense over the sickest people. The not so sick of the sickest people drop off. Enrollment keeps going down. Prices keep going up. It also, in a way, threatens the access goal in a different way. We may redefine the access problem. Why? A plan, if we don't have adequate risk adjustment, seeing a sick patient come through the door may say, here comes trouble, and may choose to treat that patient in a way that's going to convince the patient that, gee, next open enrollment period, I better sign up for somebody else's plan. Or patients themselves may simply prefer, sick patients may prefer fee-for-service plans, for example. Whatever, if there isn't adequate risk adjustment, it's a serious problem that could leave these patients feeling like they're the queen of spades in a game of hearts.
Thank you, Joe. We'll now move to questions from the audience. We have a microphone here and another one over here. There are no microphones upstairs, so those of you upstairs who want to ask a question will need to come down. What we ask you to do is line up. We'll alternate going from side to side. And please give us a name and identification and quickly ask your question. Yes.
Well, I'll start with one, just an aspect of Professor Blenden's presentation. It seems to me that if nothing else, setting aside questions about polling techniques and questions, that the resilience of support for single payer is, to me, very remarkable, given that it hasn't, in my view, been getting adequate attention. The money is on the other side of the issue. So I think a third in recent polling still for single payer deserves some attention. I also think that there has been, as I understand it, some focus groups, maybe you know more about this, that have shown more solid support for single payer. But the remaining question is, there's a difference between a one-third, 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 as you described it in the slide that you showed, and going to the conclusion that the other two-thirds would necessarily be opposed. And I think the question is, with leadership on one side or the other of the issue, that other people could be brought along with adequate understanding.
Bob?
The first point I agree with, in that I believe that we have not had an honest national debate about the single payer option. I think Americans have not been given a choice, and I think we'd see some shift. At the same time, and we could go on for a long time, and I've run focus groups with groups like the Washington Post, New York Times, not people who are paid on one side or the other. And what we're dealing with is an incredible anti-government feeling. And so in focus groups, people say, I can't trust the insurance companies. It's a terrible thing. But then they ask about the deficit. And then they say, if you can't control the deficit, why will they do that? And people are paralyzed. So if you ask me where America is, America does not, and we've done all kinds, the LA Times, all kinds of quite objective studies of this, are not willing to buy a single payer at this time. But 3 to 5 years from now, if this doesn't work, and I'll tell you that I mean this quite strongly, that if the plans that are being put forward don't work, Americans, I think, would be willing to look at another option. But I think the anti-government feeling is so strong that it's not a matter of just a debate. It'd be hard to convince a lot of Americans to trust so much to the government, independent of what I think are very objective evidence that single-payer could very well work in this country.
Okay, thank you.
Yes.
Again, I just want to ask people to state your name and then ask your question.
Yes, my name is Roy Glasser. I've been listening very carefully. I was very impressed with some of the slide information, partly because I reached some of the conclusions myself before. I have developed a health plan which would allow reductions in cost to 40% of what they are currently. If I were to send it to you, gentlemen, would you perhaps be able to review it and perhaps find something that might be worth carrying on to the people?
Sure.
Would I send, okay, would I send that to Mr. Donaldson, rather than giving me the information, would I send it to Mr. Donaldson and perhaps also to you, Dr. Blenden?
Yes?
Okay, thank you.
Okay. Yes.
My name is Samuel Silverman of Watertown. I'm one of those seniors who were so scantily alluded to tonight. And I, for one, feel as though I have been zapped. In the first place, thanks to the blessings of the Waxman bill, they've pulled the rug from under us in terms of Medicaid eligibility. And not one of you very, very learned gentlemen has seen fit to even refer to the subject of Medicaid. And I had been told by no less a person than the secretary in Senator Kennedy's office that, yes, Senator Kennedy himself was in favor of this Waxman bill because the philosophy behind it was that people who have assets should not utilize the Medicaid thing, and that we were going to see the long-term care situation addressed in this new health bill that was yet to come. Where the devil is it?
Someone want to take that one?
The president, as Bob Blenden explained to you, had created some ideas in his speech. One was that the seniors were going to get long-term care. As I read the plan, whatever increase in long-term care is going to be dumped into the present Medicaid responsibilities of the state, funded with a block grant that's about the same that the states are getting now, and you have to fight with your good governor to get long-term care away from poor people or other poor people, as the case may be, in the state of Massachusetts. It wasn't a very clear increase in long-term care, and I think I don't believe it's in there. The Henry's, I'm not sure what the Waxman bill it is you're talking about. Henry Waxman generally has been the champion of protecting the more fragile members of our society and making sure that their benefits are not taken away from them. So I would be surprised if anything that Henry would support would lessen the treatment of the provision of benefits to seniors, impoverished seniors. I guess the reason we didn't say much more about Medicare is, while I suspect that inherent in the plan is a formula to disassemble Medicare, probably 5 years if the plan works the way it's purported to. I'm sure we're not going to let that happen. I don't know, and Bob could tell you more about this than I can. I think Medicare is a rather relatively popular plan.
Medicare or Medicaid?
Medicare. Mm-hmm. And many Medicare beneficiaries are also Medicaid beneficiaries at the same time. But I don't think you'd find a senior, certainly not one that graduated from Harvard, that would not take Medicare, largely because they couldn't get any insurance anyplace else. And I don't know of a hospital or a doctor that won't take Medicare patients. They all grump a little, but I think they all love it. And so I don't, and the First Lady had said unequivocally the other day that she's going to protect it, but I'm not sure that she knows what the plan does to it. So.
Well, Mr. Waxman has skewered the middle class on the issue of Medicaid. Thank you.
Oh, tell him.
Yes.
I'm Matt Taylor, and I am for a major change in our healthcare system, but I feel that both the Democrats and the Republicans are headed in the wrong direction. And I was wondering if anyone on the panel has heard any arguments for the decriminalization of self-medication, and if you'd comment on that.
I have been supporting decriminalization of a variety of controlled substances since the 60s, but I don't usually run on that platform, but I don't know. I don't know to what you refer other than that.
Let's say that I want to put minoxidil on my head. I have to go to a doctor who is licensed by some government bureaucracy to get permission to do that. Then I have to go to a licensed pharmacist and buy it from there. I can't go to Stop and Shop and buy that on the shelf and put it on my head. And if there was no government bureaucracy regulating this person, and controlling this, controlling that, it would be much less expensive for the taxpayer and much simpler for me.
Well, since Mary Baker Eddy, I guess, is no longer converting the same number of people to that school of medicine, I would have no objection. And I have always suggested that in medical care, save those procedures or products which could be proven to be toxic or lethal. I don't really care. I think you should have the opportunity to treat yourself as you choose. Now, that goes with the caveat that there are those who would sell you products under that who might turn your head a little and get you to take stuff that is good for you. But I don't think that in this government regulation that one can suggest that we've been overly restrictive of the opportunity for experimental or individual attempts. But you got to find a fine balance. I mean, I still like to get on the plane when I fly up here and know that somebody's given that pilot a test besides me.
But
and
there could be a non-government agency like Underwriters Laboratory. But very quickly, will you be exempting yourself from this plan?
no, as a matter of fact, I have a resolution in, unlike my friends in the Senate who wimped out, that we must, not only must we be in the plan, we must be in the plan at the lowest price premium in our home districts, and then this gentleman's concerned about Medicaid and others, I think will be well served.
Yes, to the right.
I'm Don Lee. I'm an undergraduate here, and yeah, I care about, I guess, the poor recipients too. I have a question for Professor Newhouse. I was wondering what you meant by the budgets at the state level will increase, and you gave the example of Medicare, but I thought states were only paying for, states only help to pay for Medicaid. I was wondering about why the state budgets for healthcare increases. And do you think states will, what will states' role be and what should they be? I mean, can they help the healthcare system?
Well, as the Congressman said, the state's role is one of the great unsettled questions in this debate. And as he also indicated, if 50 states head off in 50 different directions, that might not be necessarily the best outcome if we decide that 10 years from now some of those directions aren't so hot. Now, I did not, let me clarify my points, 2 points. First of all, the bill, and I imagine several like it, propose that spending be regulated by a geographic entity that is either a state or a sub-state area. Specifically in this bill, the so-called Health Alliance is to regulate spending, and those alliances will either be coterminous with a state or there will be several alliances in a state that don't overlap. Those entities are supposed to control spending. My point was initially, we don't really know where we're starting out. All right, so the issue is how do you set the budget if you're running the alliance for the state of Massachusetts when you don't know what Massachusetts is spending now on its residents? We know roughly what Massachusetts spends to produce medical care, but that also includes what it spends to treat people who come over the border from New Hampshire, Rhode Island, et cetera. that was point one. Point two is there's a lot of year-to-year volatility in these budgets, but in what we spend now. Exactly why there's all this volatility is far from clear. At least it's not clear to me, but it seems to be there, which I think is going to be a practical problem when one comes to actually implement budgets, and it's going to be more volatile at the sub-state level.
Yes.
Okay. My name is Sandra Bennett. I have two questions regarding Medicare. One, under the President's plan, will current recipients of Medicare be allowed to choose whether to opt for a plan under the Alliance, particularly the fee-for-service plan, either contingent upon paying additional premium or not? And second, under the present Medigap policies, disabled people are not required to be included under those policies. I wonder if Congress is going to legislate a plan, and if it's envisioned under the President's plan that exclusions by the private insurers for Medigap policies that supplement Medicare will be permitted for disabled people. That's my two questions.
Well, I think, and I, not having the complete open enrollment in the Medigap policies is one of the tragedies of the bill we wrote recently. We thought we reformed it some, but we didn't do a complete job. There are many of us who would still like to do that. My hope would be, and I think the President would support it, that he says there will be no exclusions for pre-existing conditions in any plan, and I'm certainly going to hold him to his word. And the other issue, as I read it, the President says that people, if they are in an alliance and the alliance has shown that it meets quality standards and is able, and I presume by that he means over time, when a person becomes eligible for Medicare, they can opt to stay in the alliance rather than, and in whatever plan they have in this alliance, be it an HMO or a fee-for-service plan, rather than go into the Medicare program. Also, he has provided in there an option for states, if they show their ability to perform, to take over the Medicare patients in that state in their entirety. And with proper safeguards, I suspect that would be all right, save one thing. It is that because the benefits that the President has suggested in his plan are substantially more generous than the Medicare benefits that exist today, it eludes me as to why anybody would come into Medicare. I mean by like $100 a month minimum. And I don't think you have to go to Harvard to figure out that you better stay in your present plan if you like it, rather than pay at least $100 more to go over into Medicare. And that is why I said it's a plan for unwinding Medicare. In about 5 years, I will lose my base, the younger, more healthy members of Medicare who are paying for my mom. And so it's either I'll lose the revenue and the trust fund will go broke, or I'll lose enough members and the plan will disintegrate. So whatever the First Lady says about protecting Medicare, the plan seems to me to be a formula to dissolve it. However, relative to, I think, the question you ask, is it is the President's plan to allow people the option to have another program other than Medicare when they qualify. And he suggests that there will be adequate protections. Whether that'll finally end up or not, I don't know.
That wasn't quite my question, because I did speedily have read to me the section on Medicare. I need to reread it to be sure. And I did see the provision about when you reach 65, you have a choice. But I didn't notice any provision except some complicated language about joining managed care plans.
Yes, I don't think
that, excuse me, that states that people who are now on Medicare have a choice between Medicare and choosing any plan under an alliance that they choose, including fee-for-service, and precisely for the reason you said, that the President's plan benefit package might prove to be more generous than the Medicare package. I would think that current recipients might want the choice, and particularly current recipients who can afford to pay for a fee-for-service plan might want the higher benefits?
That, you're quite right. However, Medicare is a fee-for-service plan, and if they're willing to pay, I can't imagine there's anything they could get in another plan they can't get in Medicare. But you're right in your interpretation. The only way that I read that a current Medicare beneficiary could have other than Medicare would be if the state in which that beneficiary resided were allowed to take over the Medicare responsibility in a state plan.
Okay, thank you. Next question.
Saul Levin, I'm a mid-career Master of Public Administration student. I need to at least declare 2 conflicts of interest. One is that I'm a psychiatrist and therefore obviously have a great interest in how the physicians are going to ultimately come out in the plan. And 2, I will be returning to the administration to take up a position when I leave here. I think the question I have, having listened to all 3 of you, is while it was enlightening to hear and I think entertaining at times,
But only
one thing I didn't hear is we are now a little better off than what we were a year ago under the Bush administration. And Congressman Stark, you actually came and spoke at one of the conferences I did under that administration where you spoke similar to what you've said now. The question is, you've all said what is not going to work in this plan. The one thing I didn't hear from all 3 speakers was, well, how are we going to fix it? And I think if we do look at the plan, and I think both President and Mrs. Clinton have said, we realize this is not the ideal plan, but it is at least a start to begin to reform the healthcare system, and that we're open to debate on it, but that we cannot go back to where we were. I'm hearing you saying, well, it's not going to work, without giving any alternatives. I need to add one thing when we talk about single-payer system. We do in some ways have a single-payer system for some people in this country that is government-controlled. The Indian Health Service,
Medicare,
and Medicare.
Okay.
And
Can you get
I'm
to
not
your
too sure
question?
any of the country would want to go under those 2 systems in the present form. I'd like to know what are your alternatives for the current plan and how you see it ultimately coming out as an alternative to what's being proposed.
Why don't I save that for the finale and we'll let the other people have their question. I'd be happy to answer it, but it's not in fairness to the other people who want to ask questions. I'm not sure you want the long answer at this point. I'd be glad if there's time to give you a thought of how I think it might work out. I think it's a good base to build on.
Yeah, I think you might want to come up and speak later. We have time for one more question.
My name is Patricia Savage. I'm a first-year Master's in Public Policy student here, and I have a question for Mr. Blenden about the public's attitude toward doctors as a whole. I saw the article this morning in the New York Times about the AMA's assault on President Clinton's plan, and I just wonder if patients are going to trust their doctor's viewpoint that they should be opposed to this because it's not good for them as the patient, or if they're going to think, no, my doctor wants me to oppose this because it's not good for his salary or her salary.
Actually, you hit the whole issue. If Americans think that the medical community's attack is strictly based on their economics, it'll get nowhere. But if they're able to raise the fear that people actually won't get care and things will change, they'll make a difference. One of the things, if you're in the studies with this, if the ads are identified as the American Medical Association, it's a loser. If they get a committee of citizens together, and it's doctors and citizens together, including seniors, then it'll make a big difference. But let me close with a very important point here. I believe from the world I'm in, actually the most important determinant of where this debate goes is going to be the public's view of Mrs. Clinton. Because what's going to happen, and this is really quite strange, these accusations are going to come out, and those of us, even who are experts, are going to doubt some of the things. And the question is ultimately, who do we believe? And the president has a real problem. It's actually not going to be him. And so the question is, when there are lots of people on television and radio saying there's something wrong, if she is strong enough, Americans will take a chance with her. And so this is actually historical not only for the First Lady, but no sort of major piece of legislation has ever rested literally on the question is, do you trust Mrs. Clinton? Would she actually do to old people and children what the American Medical Association is suggesting? And so that's what it's going to come down to in a lot of people, because you'll listen back and forth. Do them in, don't do them in. Can save it, not do it. Who do you trust? That's how it's going to be resolved.
Thank you very much. Thank you, Congressman Stark, Professor Blenden, and Professor Newhouse. We will advertise the next event in our series, so read the agenda and look for posters.
Sir, well, tomorrow you're going to have